Over to Dr. Soumya for the first Is My Child Seeing? Dr. Soumya Nambiar, she is our consultant pediatric ophthalmologist at Comtrust Eye Hospital. She has been in Talasheri Comtrust Eye Hospital for some time. Now she is in Calicut. Over to Dr. Soumya.
Thank you, ma'am. First of all, I would like to thank Laila ma'am and KSOS for having given me this opportunity. So vision, we know that it requires a lot of processing, lot of attention, especially when it is a chaos like this. You need to have a lot of clarity into what you're seeing. So let's compare these two infants. So you can see in the first case, the child is using both his hands. It's a 6-month-old child, and see how nicely the child is taking up the toy, tries to feel it with her mouth, and looking at the toys when it is brought closer. The same way in the lower down, you can see how the child, you have shown an illuminated toy. It tends to attract the child, but you can see the child is showing some attention and suddenly zip off. The child loses the attention. Okay, it's almost the same age child. So what's happening here? So this is what we day in and day out as pediatric ophthalmologists see, especially in infants. They are crying and we are crying in our mind, what's happening? Is my child seeing? The common causes what we have to think about is congenital globe anomalies, cataracts, corneal opacities, retinal dystrophies, glaucoma, amblyopia. This is what our session is going to deal with. And today, what I am going to deal with is the abnormality of the higher visual pathways. So basically what happens in this? This is what we all know is cerebral visual impairment. Okay. So what we deal with, we all have seen adults coming with cerebral visual impairment. But the same thing, does it imply to the infants as well? So this cerebral visual impairment is a major cause of profound visual impairment in children aged less than 3 years. This is a study done in Tertiary Eye Care Center in South India. And their data tells that cerebral visual impairment and optic neuropathy have become the most common cause of visual impairment in children. So what is CVI? So basically it is a verifiable visual dysfunction. What I mean by that is when you see the visual acuity of this child or visual dysfunction, when you measure the vision, it varies from time to time. It varies from place to place. You test the child in a different environment, you may get a different finding, okay? And why does this happen? It happens because of the damage to the retrogeniculate pathway. So you cannot attribute all of these visual dysfunction that the child has to only the anterior visual pathway. That is when the bells has to ring that probably there's something else wrong. And usually they tend to be associated with other neurological conditions like cerebral palsy. So why is it important, especially in infants? And early identification is very much necessary because the neuroplasticity occurs maximum in the first 3 years of life, and any response to the intervention is at most in this period. So we know that the front of the brain thinks, the middle feels and moves, and the back sees. Right? So you all know all this with the usual cerebral visual impairment thing, how our vision processes. That is, whatever we see goes to the occipital cortex, goes through 2 streams. One is the dorsal stream, which is the where system, which tells us or helps us understand where things are, and that goes through the posterior parietal lobe. The other one is the ventral stream, which is called as a Watt system, and that is through the temporal lobe. Now, is the CVI gaining importance? Yes. CVI, as I told, is the leading cause of visual impairment. It is leading because there is increasing incidence, there is increasing awareness, more surviving premature babies, and better neonatal care coming up. So the most common causes of cerebral visual impairment is hypoxic ischemic encephalopathy, which is found to be most common cause. Other than that, you can see hypoglycemia, seizures, stroke, metabolic disease, infection, all this can cause. And that is when your history becomes important. You need to take the history from the parents regarding all these conditions. This is just the pathophysiology which I have shown in HIE, that is hypoxic ischemic encephalopathy. You can see those gliosis that is present around the periventricular region. That is called as PVL, periventricular leukomalacia. So how do you identify these cases? So that is where we have to think, because less than 1 year, it's very difficult to identify the children. So this is where Leah in her book has told, watch out for these 5 things in the first 3 years. So you can see that here the child is a 8-week child. See how the child is mimicking the facial expression of the parent. Okay. So whenever you see a child who has a delay in development of eye contact by 8 weeks, think of CVI. Whenever you see a child who has a delay in developing social smile by 3rd month, think of CVI. Same way, a delay in awareness of hands and hand regard by 3rd month, think of this. There will be a delay in goal-directed hand-arm movement for reaching and grasping. You can see the child is learning how to do the orientation of the balls, colorful balls. So by 5 to 6 months, if this doesn't develop, you have to think. There is a delay in recognition of facial features by 7 to 10 months, think of CVI. So how do you assess? So in CVI, for adult CVI or for the elderly age group, pediatric age group, we do have a CVI questionnaire. But for infants also, we do have what is called as the pre-visual assessment questionnaire. Okay, so you can see here that this is a very crowded slide, but there are 30 questions. You can see each question will help in assessing what is the visual acuity of the child, what is the visual motor coordination of the child, where the visual processing is affected, that is VP. So each of these questions will help to get an idea of what is there. And remember, you have to differentiate between what is ocular visual impairment and cerebral visual impairment. Both can coexist. So how do you start assessing? Always check the functional visual acuity of the child. Then look for the refractive state. A high refractive state should never be missed. Do an anterior segment examination, do a fundoscopy, do a visual field assessment. So as I told, the functional visual assessment, as you can see, here what we use is called as the LIA paddles. You can see the gratings which are present on the paddles. Okay, so the child will respond to the gratings. So it will help. How does that help? It helps us in assessing at what distance the child is able to see, at what distance you need to train the child. Okay, so this is what it helps. So you can see here, the child is responding to the illuminated toys. So you can train the child with that. You can use this illuminated toys to train the child. Here you can see when you shine the bright light, whether the child is blinking or not. So it's a blink reflex that is present. So there is some amount of vision that is present. Another way you can quantify is what is called as a teleacuity. See here you can see the child is uniocularly patched and then you're testing. Okay. You can use a contrast sensitivity. So as you can see, these facial expressions help us in seeing how much the child can see your facial expressions. If the child is not able to see or has a low contrast, you can tell the parents or mother to use makeup or enhance the contrast of the face. So always look out for these visual behaviors. So as you can see in this child, you can see that there is a delay. What can you see? There's a delay in the child seeing the toys. In this case, if you can see, as the size of the beads are going, you can see that the child has difficulty. Okay, and the child is not using the pincer grasp, he is using the whole of the palm to take up the bead. See, as the size of the bead is reducing, the child is going French to see the, to take the bead. This is what you call it as the visual guided race. So just carefully look at the photo. As you get the toy, just there will be a sudden tilt of the head, see, and then the child takes up. So therefore, as I told, early intervention is very important. And this is how we do. We have to train, that is do visual stimulation, do environmental modifications and visual training. Start off with your glass correction first and do these modifications in the environment that you can do. And always teach them to use other senses like touch and hear. Okay? And always watch out for these red flags for CVI. So basically, it's a teamwork. And you have to include your pediatric neurologist and other speech therapists also into your training period. Thank you, one and all.
Thank you, Soumya, for that wonderful